Okay, so moving on, coronary heart disease. Coronary heart disease or coronary artery disease, or it could be called ischemic heart disease. It results from insufficient blood flow from the coronary arteries into the heart or the myocardium. So disorders associated with this condition are arterial sclerotic heart disease. It could also be angina pectoris, coronary insufficiency, or MI or a heart attack. So what is it? So the major cause of coronary heart disease is atherosclerosis, or a narrowing of the lumen of the coronary arteries, and because of that narrowing of the artery, then of course blood flow volume is diminished. So narrowing of the lumen is caused by kind of fibro-fatty deposits that build up along the lining of the inside of the vessel. So they contain lipids and cholesterol. And the deposits, they thicken with time, and they eventually can completely occlude the vessel. Let's see. Okay. So risk factors are kind of staying pretty similar to other cardiovascular diseases. We have age, gender, race, diet, environment, tobacco, and then chronic inflammation. So other causes of coronary heart disease are congenital abnormalities of the arteries and changes in arteries because of infection, an autoimmune disorder, and coronary embolism or a blood clot. So in addition, research does support the association between inflammation in the body and coronary heart disease. So what they do is they test for C-reactive proteins, or CRP. They test for the CRP levels, and these are used to determine your systemic inflammation, overall an individual's systemic inflammation, and how that's associated with disease, including an individual's risk for heart disease or cardiovascular disease. So elevated C-reactive protein levels are key markers of atherosclerotic conditions, and then studies have also correlated this increase of CRPs or C-reactive proteins with the presence of periodontal disease or periodontitis. So findings support, these studies suggest that there's some kind of a correlation, like we mentioned in the beginning, of periodontitis increasing one's risk for cardiovascular disease. So the link is not known specifically, it's still unclear, but evidence does suggest a relationship. And this is part of what is so important for our patients to understand, at least this piece. We don't know exactly how it's affected, but we know there is a relationship there. So we'll break it down a little bit to the coronary heart diseases. The first one would be angina pectoris. So what's happening? Angina pectoris is the direct result of inadequate oxygen flow to the myocardium. So it's manifested clinically as sort of a burning, a squeezing, or a crushing tightness in the chest that radiates to the left arm, the neck, and the shoulder blade. If an emergency develops, dental hygiene treatment is stopped. The patient is placed upright. So we bring our patient up to a seated position. We want to reassure them, try and help them stay calm, give them their nitroglycerin sublingually. They will probably be very, very astute to what they need to do, so they'll probably take a very active role and won't likely freak out if they're used to this sort of thing. If they take their sublingual nitro and their pain has not gone away, oftentimes then EMS is activated, especially if the patient continues to have. And they may say, sometimes I have to take 2 doses, or they may tell you what's normal for them, but you will have asked them in the beginning when they mark their medical history that they have angina. You'll ask them things like, how often do you have attacks? When was your last one? How long do they last? Does your nitro work after the first dose? Things like that. You also want to monitor their vital signs, so taking their blood pressure and pulse. And they'll know this, but it's important for you to know this, that their nitroglycerin potency is lost after 6 months. So there should always be a fresh container of nitroglycerin in the office, a medical emergency kit. So myocardial infarction is the second manifestation of coronary heart disease. It is a reduction of blood flow through one of the coronary arteries, resulting in an infarct. An infarct is an area of tissue that undergoes necrosis because of no blood flow. So it's dying because there's no blood to that area. An MI, or a myocardial infarction, is most commonly known as a heart attack. It can also be known as a coronary occlusion or a coronary thrombosis. So we know, I already said what's happening, reduction of blood flow. So for a dental hygiene appointment with a patient who's had a history of an MI with no complications, treatment isn't really altered. They may be taking medications that have some oral implications, but there's, as long as they're stable and there's no complications, there's really not much different. Now, if they've had their heart attack within 30 days, you postpone the treatment until they've reached the 30-day mark. I have worked for doctors that actually don't want to see a patient until they've reached somewhere between the 3 to 6 month mark, but that is probably very conservative, and the physician can always be consulted. The physician may say, oh no, they're totally fine for a dental appointment. So it's, again, it's that interprofessional piece. We always want to reach out and if we're unsure. And then drug therapies that are oftentimes seen with a patient who's had a history of an MI is anticoagulants, digitalis, and antihypertensive drugs. Digitalis can have lots of oral manifestations, and you'll see that in the table at the end of this PowerPoint. It's important for us to know all of these oral manifestations with these drugs, especially since a lot of patients are on these drugs because there's a lot of heart disease in the world. Other considerations, clarifying the symptoms after 30 days, if they're stable or if they're unstable. We want short, typically morning appointments are more comfortable for patients. We want to reduce the stress of the appointment. We want to make sure that the patient has adequate pain control. We can always use nitrous on them if there's no other contraindications. And then we really want to talk to them about their lifestyle. So given that periodontal disease is a risk factor for coronary heart disease, patients need this information to make sound decisions about their oral health. So we should educate them to emphasize that link between oral disease and systemic disease. So by stressing the importance of oral disease prevention, then we promote active self-care. And that, of course, encourages them to take active self-care in other areas of their life. So in that way, we're a co-therapist for nutritionists and heart doctors and other specialists. So when we teach them self-care behaviors to maintain their oral health, it encourages them to participate in formulating goals for care that establish overall health and that reduce their risk for periodontal disease, and we encourage them to have regular periodontal maintenance or preventative care, and then we help to facilitate these choices and help them to make their decisions. So it intertwines what we do specifically with their lifestyle and with their other systemic diseases. Dysrhythmias and arrhythmias, what are they? Cardiac dysrhythmias and arrhythmias, the terms are used interchangeably. They are a dysfunction of a heart rate and rhythm that manifest in heart palpitations. Dysrhythmias pretty much are seen in, we refer to it in a diseased heart. Arrhythmias are more of an emotional or physical stress. So dysrhythmias may develop in a normal and a diseased heart, like we mentioned in the slide before. In healthy hearts, arrhythmias may be associated with physical and emotional stress, such as exercise, emotional shock, usually subside in direct response to stimulus reduction. Diseased hearts develop dysrhythmias directly associated with cardiovascular disease, most commonly valvular heart disease, arteriosclerotic heart disease, or coronary artery disease. And in some cases, a cardiac dysrhythmia may develop in response to drug toxicities and electrolyte imbalances. So we, of course, want to mitigate stress in our patients during appointments. Dysfunctional disturbances of nerve impulses is also part of the dysrhythmia and arrhythmias, and they are oftentimes diagnosed through echocardiograms, EKGs or ECGs in the hospital or in a doctor's office, or they may be wearing a monitoring system for an outpatient monitoring. So the common types of dysrhythmias and arrhythmias would be bradycardia, which is a decrease in the heart rate and it declines to less than 60 beats per minute. Tachycardia is an increase in the heartbeat greater than 100 beats per minute. Atrial fibrillation is rapid, uneven, and irregular contractions in the upper chamber of the heart or the atrium due to irregular impulses. Premature ventricular contractions is a pause in an otherwise normal heart rhythm in resting phase when contraction arrives or is skipping a beat. And then ventricular fibrillation is the really bad ones. That's the lethal one. It's the rapid impulse formation and transmission leading to heart rate that's rapid and disordered. It's basically described as no rhythm or a jiggling. So there's no contraction, there's no pumping. It's just like kind of jiggling. The heart's just not doing anything that's effective, that's actually moving blood. And then heart block, let me get to my notes on heart block, is a dysrhythmia caused by the blocking of the impulses from the atria to the ventricles and the AV node. It's interference with the electrical impulses controlling the heart muscle. And there are 3 degrees of heart block. The first degree is seen in coronary artery disease or in digitalis drug therapy, and it can be asymptomatic. The second degree of heart block is impulses are fully blocked in irregular patterns, and then the third degree is a blocking of impulses resulting in atrial and ventricular disassociation, independent heartbeat from the atrium. So that is the most dangerous, is the third degree of heart block. So patients with a pacemaker is an intracardiac device, an electronic stimulator used to send electrical currents to the myocardium to maintain or control their heart rate. There's a shielded or a non-shielded. We have to think about patients who come into the clinic and the huge use of electronic devices and ultrasonics. Half the clinic may be using, not currently, obviously, because currently at the time of this recording, we're not using ultrasonics in our clinic, but typically we maybe half the clinic could be using an ultrasonic, and so we have to consider the patient's type, if it's shielded or non-shielded, and we can ask them. Non-shielded, you could use a lead apron. Shielded, you can continue treatment as normal, and if you're unsure, you can consult the cardiologist. Many pacemakers are shielded nowadays, so I think that's not as common, but it still should be considered. Malfunctioning pacemakers, patients could have difficulty breathing, feeling dizzy, change in their pulse rate, or they could have chest pain. Turn off electrical interferences, activate EMS, and CPR or basic life support. cardiac dysrhythmias and arrhythmias consideration for a dental hygiene appointment. So there's no need for pre-medication. You want to consider their drug therapy, and the oral manifestations could be the same as other heart conditions such as antihypertensive drugs or anticoagulants. We want to, again, think about the shielding of a pacemaker. Unshielded is less common, but we want to be aware and ask the patient. And you could put a lead apron on them if they happen to have an unshielded pacemaker. Manual rather than electrical dental equipment as well. So hand scaling rather than ultrasonics if they have an unshielded pacemaker. Monitor and record their vital signs, and monitor patient throughout the appointment. Okay, so I'm going to stop there, and then we'll go to congestive heart failure in the next video.